morning. Why don't we get started? It's my pleasure to introduce Andy Krystal, who I've known for many years from the sleep world, the sleep community. And we've been lucky to have Andy since 2016, where he's starting the second half of his career here as the Vice Chair of Research here, and he's the Ray and Dagmar Dolby Distinguished Chair. He actually wears many hats. He directs our our sleep research laboratory here, runs the mood and anxiety disorders program. And so Andy is trained at MIT in biomedical engineering, where he has undergraduate and master's. And then he went and got his medical school training and stayed at Duke for many years in residency training, and did multiple fellowships in sleep as well as in actual neurophysiology. He's boarded in EEG in addition to sleep medicine. And Andy is probably the leading authority in the world in insomnia pharmacology, and but his interests are actually broader than that. He's broadly interested in biomarkers, EEG in particular, sleep EEG or clinical EEG. He's also done work with TMS, and it's all in the service of directing treatment choices. So at the end of the day, he's always interested in developing ways of informing treatment decisions, which is really the heart of the talk that you're going to give today. Andy has won numerous awards at Duke, and probably what really stands out are his teaching awards. I mean, if you've interacted with him, he clearly loves to teach. He loves to mentor. He gets excited about your ideas, and he gets you and makes you excited about your ideas. So it's a real pleasure to have him here. We're very lucky to have Andy here. And I look forward to your talk on individualized treatment for insomnia.
Thank you, Tom. Let's see. It's going to take a second for the computer to turn on. I feel real fortunate to be part of this department. It's been about a year and a half now, but I really sort of feel part of it since January. I've had 3 projects going on at Duke for the last year and a half that have caused me to have to go back and forth, and so finally that's over, and I can feel both feet on the ground here. Well, let's see, how do I pull this up? There we go. Okay. So first, okay. So my disclosures. There won't be any board exam questions in this talk. Unfortunately, bound to have to include that in every talk I give. This is the diagnostic criteria for insomnia, and just wanted to make sure everybody knew what we were talking about today. Everybody has an intuitive sense about what insomnia is and deals with it all the time, in some ways, because it affects roughly 15 to 20% of the population. Is this one of these a laser pointer? Uh-oh. No, that was not the laser pointer. Top button. Oh, got it. Okay. But I just want to draw your attention to the bottom part, because that's what's often missed, that it has to be associated with impairment in function or quality of life. We have many people who sleep less than others, or are short sleepers, but they don't have any impairments, and we wouldn't call that a problem. They don't call it a problem. So the point of my talk today, and a lot of the work that I've done over the last 30 years, has been to try and address what was pretty surprising to me when I first entered the field of sleep research, that people thought of insomnia as a unitary phenomenon. They tended to choose one intervention to treat the condition, let's say Ambien, and use this for everybody, and not see the heterogeneity that I saw in the insomnia population. There's a very complicated set of people with a complicated set of problems that have differing contexts and causes. And it was actually the most surprising thing to me was when I started in the field. There was a common occurrence where I would talk to people who were practicing medicine, and I would say, well, how do you treat this condition? And they'd say, well, I use Benadryl, or I use an antipsychotic, or whatever. And people would say, my strategy is to use no interventions that are approved by the FDA for treating this condition. Basically, I was puzzled by this, and I mean, there were concerns because of history about abuse potential and other kinds of things. But for many years, that was the state of affairs, and it really was astounding to me. And to the extent that there was any tailoring of treatment going on, it would be related to using a drug, let's say, that helped people fall asleep in people who had trouble falling asleep or trouble staying asleep. They would use something else. But for example, Zolpidem and Zolpidem, Ambien, are drugs that are approved for helping people fall asleep but not stay asleep. But remarkably, most people ignore that and use them for everybody. Usually Ambien might be used in any given patient. And the model that prevailed in the field for many years, and I think still is a prevailing model, is that your drug effects are proportional to blood level. That is, pharmacokinetics are driven by pharmacodynamics, and that's the only thing that matters in terms of differences among drugs that we might use, which turns out to be flat wrong, but that was the model. And so really the impetus behind the idea that we might be able to personalize therapy for people, that is, target specific interventions to specific people, has emerged in the context of there being interventions available that are targeted to specific types of problems, and evidence that that's the case, and also new data on existing agents and interventions that speak to how we might be able to use them in a strategy that's a personalized approach. Some of the newer agents are highly specific in their effects, and that's really partly going to help us able to tease these issues out. Because in the past, the drugs we had were relatively nonspecific pharmacologically. So the possibility is you can have a paradigm where you match people to a type of treatment that best suits their needs, and why would we bother doing that? Because it improves our risk-benefit ratio. If you use a strategy that's global, it means you're doing things that aren't needed to an individual, and usually that comes at a cost, and in treating insomnia that's the case. If we use drugs that basically shut down all aspects of the brain, or many of the aspects of the brain, then those aspects of the brain that are not needed to be affected are basically side effects. And so our risk-benefit ratio is improved by a tailored approach. Well, where are we on this? That's what I'm going to talk about. It's a work in progress. And I'm going to try and review the existing drugs we have and treatments we have, and talk about what we know about tailoring, at least as I see it. So there are two primary approaches: cognitive behavioral therapy and medication management. And I'm going to start with talking about cognitive behavioral therapy. So for those of you who don't know Eric Prather is there. Eric, raise your hand. So Eric is one of the leaders in the field of behavioral sleep medicine and cognitive behavioral therapy, and he provides that service for people here who might need that for their patients. We have a sleep clinic, which he and I work in, that applies this therapy and other therapies for patients. And I think the general strategy is that you're trying to address maladaptive behaviors and cognitions with this approach that perpetuate insomnia. But we hypothesized that we might be able to identify physiologic targets that the treatment was hitting in terms of homeostatic sleep drive, which is the tendency that we have to feel the need to sleep the longer that we are awake. So the more hours we're awake, the more sleepy we feel. That's a homeostatic, a feedback process. And then there's arousal, which I think we all know what that means. So we did a study to test the hypothesis that sleep EEG measures that have been linked to this homeostatic sleep process and arousal might predict who got better with CBT and might change in conjunction with cognitive behavioral therapy for insomnia. So I went backwards, I think, when I meant to go forwards. There we go. So we found, in fact, that that was the case, that there was quite a high level of correlation between, so these are the predictors of treatment before you would administer therapy, and we have a number of significant correlates that is more rapid decline in the delta power over the night, and I'll show you what I mean by that. Higher initial delta power. These indicate a decrease in homeostatic sleep drive in people who get better. That is, people have undermined the process that makes you feel sleepy at bedtime and helps you sleep through the night, and that is partly explained why people who have sleep difficulty, who have insomnia. And then this is a measure of arousal level, and the more arousal we have, the more difficult it is to sleep. The way I think of this is that we have a built-in override for sleep based on arousal. If it were not the case, we probably would not have survived, or at least it would have been much, much harder. Because imagine yourself, out in the savannah or something, walking around, and a tiger comes by and starts chasing you, and you start to run away, but then it becomes your bedtime. So you lie down and go to sleep, and you get eaten, right? So we have to have some mechanism that overrides that normal process, otherwise we would be in serious trouble in certain circumstances, like your theses do, right, or whatever. I mean, that level of arousal can overcome a whole lot of sleep drive. But there's a cost, and the cost is stuff like insomnia when we might not want to have it when we're under stress, like the night before an exam, or when you have stress coming from external features in your life that you would like not to affect you adversely. The other thing we found is that these parameters normalize when you get treatment. That is, your decrease in homeostatic sleep drive gets improved, and you get an increase in homeostatic sleep drive from treatment, and your arousal level goes down. And the homeostatic sleep drive correlated strongly with the period since you last slept. That was our hypothesis, but actually, strangely, nobody had really ever shown this in insomnia therapy before, and that was, very strongly related. I had a junior faculty member who worked with me who was Belgian and spoke French and made all of his figures in French. This is percent delta, and this is time in minutes, and this is delta power over the night, and I don't speak French at all, so that was a problem at times. But and this just shows you that when you've been up a long time, you get an increase in the low frequency activity in the EEG at the beginning of the night, and you get a more rapid decline. So people with insomnia have a flatter slope, and after cognitive behavioral therapy, it gets steeper. I'm not suggesting that we ought to be doing overnight sleep studies and measuring this, but the correlation with the time since you were last awake is strong enough where that can be easily used as a proxy. I'm not going to be going into very much detail about things because I'm trying to cover a lot of ground in a short amount of time. But one strategy for thinking about who to give cognitive behavioral therapy for insomnia is identify people who have elevated arousal that seems to be interfering with their sleep, and you could measure this a number of ways, and the other is to look at their homeostatic sleep drive, again, either by clinical interview, by measuring with diaries or actigraphy, which is a movement sensor that allows us to track a proxy for sleep, or even full sleep studies. Another interesting sort of factor that affects who does well with cognitive behavioral therapy for insomnia, and it turns out this probably affects other therapy responses, is whether people have a loss of sleep as measured by objective measures. So there's a whole complicated story out there about whether, if somebody says I'm sleeping like 6 hours or 5 hours, what does that mean? And it in itself is a valuable independent observation that is a piece of data that we have to take into account and use. But at the same time, it turns out for many insomnia patients that doesn't match with the data we get when we do a sleep study or when we do some kind of objective measurement. And there are many reasons for this, but one of the lines of work that I've done for many years is to try and understand that, and it turns out that when people are asleep and they have a high level of arousal or loss of homeostatic sleep drive while they're asleep, there are differences in depth, if you will, that are evident in the physiology. And people who have lighter sleep report being awake more of the time. So they say, let's say I slept 7 hours. Well, they say I slept 6 hours, or sleep study says 7. That difference is proportional to the lightness measures in the EEG and sleep that we've looked at over the years. So it turns out, people have separated insomnia patients into those who have objectively measured shorter total sleep time, that is less than 6.5, 6 hours, and those who report a short total sleep time without having it on objective measures. And having short total sleep time by objective measures is a particularly malignant form of the condition, from the point of view that is associated with, there's just a paper showed that that's associated with more cognitive impairment. It's also associated with hypertension and diabetes. And we have now found in 2 studies that cognitive behavioral therapy response is diminished in these people compared to those who don't have the short total sleep time. And that's both with using overnight sleep study measures as well as using this actigraphy movement proxy for sleep. And the sensitivity and specificity of that for predicting insomnia remission is actually extremely high, at least in our study with the actigraphy. Another important dimension of potential personalization is people who have comorbid conditions with insomnia. We used to describe this as people who had symptoms of insomnia occurring because they had a psychiatric condition or a medical condition. And the more people have looked at this, the more it becomes clear that it's best thought of as 2 sort of co-occurring conditions in many people, not everybody. In some people, it really looks like a symptom. But in some people, we missed that it was probably co-occurring conditions, and partly this is because when I first started in the field, there weren't any antidepressants or anxiolytics that weren't sleep enhancing, right? We used tricyclic antidepressants and everybody had their sleep improve. We never had a situation where we weren't treating insomnia in people who had depression. But when Prozac came out and other such drugs, we started to have the possibility to observe that what happened to sleep if you didn't target an intervention to it. It took about 20 years, 15 years before people started to notice that sleep was often not getting better. And so the question is, how do the people who have insomnia occurring with depression, which is about 85% do when you target cognitive behavioral therapy to those people? And it turns out that that they do well. There's been 2 relatively large randomized controlled trials that were completed recently that showed that insomnia improves beyond what you would get with the antidepressant alone if you use an SSRI and SNRI. That's associated with improvements in quality of life and function. But interestingly, there was a hypothesis that doing that would improve depression outcomes, with, other than the sleep items of the depression. And in these 2 studies, it didn't. And I'll come back to this point later. But so who would our target patients for CBT-I? It's pretty much people who have diminished homeostatic sleep drive or elevated arousal, which is the vast majority of people who present with insomnia. And while the people who have objective shorter total sleep time don't respond as well, we don't know how that level of response compares to medications. There are robust efficacy demonstrated with the treatment of a number of insomnia agents, but there's never been any comparison, so I have no idea what the relative risk or benefit is, and that's something that has yet to be fleshed out. And then I think for people with depression and anxiety disorders, the cognitive behavioral therapy works well, and as do medications. But there is a medication that seems to improve depression along with sleep, and we'll talk about that later, and in my view, that would lean towards use of that strategy in people with this co-occurring condition, unless there's some reason not to go that way. I'm going to shift gears and talk about medications, and there are a lot, but I'm going to focus on a subset here. And this is my sort of effort to summarize the field of play. So the things that we're most familiar with are medications that have been called benzodiazepines and non-benzodiazepines. This is what established the paradigm for how we think about insomnia management, that the drug level is proportional to the therapeutic effect, higher blood level, higher sleep-enhancing effect. These drugs are all allosteric modulators of the GABA-A receptor. You probably have heard many times, or you may not have heard, I've heard many times, the term benzodiazepine receptor agonist. Is a pet peeve of mine. There's no such thing as a benzodiazepine receptor agonist because there's no such thing as a benzodiazepine receptor. There's a binding site on the GABA-A receptor complex. It's a GABA receptor. And how we know that it's not a benzodiazepine receptor is if there's no GABA around, it doesn't do anything. Right? Benzodiazepines don't do a thing unless GABA is there to open that channel and allow chloride to fly into the cell from outside the cell, hyperpolarize the cell, and make it harder to fire. That's the inhibition process that is mediated by GABA through GABA-A receptors. So these drugs bind to the binding site there and enhance the opening of the channel and enhance the effects of GABA on GABA-A receptors. They are therefore allosteric modulators as they change the conformation of these proteins. So these drugs there are two groupings, if you will, benzodiazepines, and they have in common a chemical structure that led to the name benzodiazepines being linked to them. The binding site is also called the benzodiazepine binding site after that group of medications. Non-benzodiazepines came along and they act by the same mechanism, but they are not chemically related to the benzodiazepines, which is why the FDA allowed a move which seemed radical and odd at the time. They allowed the people who developed Ambien, that's Zolpidem, to call it a non-benzodiazepine. They don't let, if you see a drug company says something, that's been vetted with the FDA, and they don't let you say things easily. But it's a true statement. These are not benzodiazepines. Ambien makers that was marketed in the U.S. by Cyril many years ago were desperate to differentiate from the benzodiazepines because of this phenomenon that I mentioned before. People were avoiding all drugs approved by the FDA because they were all these drugs. And they were concerned about abuse potential and other kinds of problems that can occur with them. So they tried to differentiate, and they used this term, and the FDA said, fine. It's equally correct to say that these are non-opiates. And amazingly enough, some makers of these class of drugs have used terms like that lately because they think it makes it seem safe to people. But anyway, these drugs have the same mechanism of action, and they have a wide set of effects on the brain. They can have therapeutic effects on anxiety, and they can be mild-relaxant. They can have anti-seizure effects, sleep-enhancing effects. But they have broad inhibitory effects, shutting down lots of areas of brain function, and that includes shutting down parts of the brain that are critical for cognition and motor function, so your reflex speed is slowed and your balance is impaired and memory is impaired and all these sorts of things. And they do have abuse potential. The abuse potential is modest, actually, compared to many things we worry about. But the problem we face in practice is that there are a set of abuse-prone individuals who will take these drugs for purposes other than prescribed, and we don't know who they are. So if anybody increases the dose for some reason, or we think that they're abusing it, usually people use these drugs for therapeutic purposes, except for it's roughly 1% to 2% that seem to be polysubstance abusers who are prone. I mean, rats and humans do not universally abuse these drugs or enjoy them. Unlike opiates and stimulants, which are pretty universally reinforcing for animals and humans, you can breed the propensity to like this drug into animals, and we breed it into humans all the time. And those who are the lucky ones or unlucky ones who inherit that are the ones at risk. So the model that emerged for management of insomnia that I inherited was that the therapeutic effects are determined by the blood level, the mechanism doesn't matter, that any way you enhance sleep, and there's no time of day effects or other kinds of effects, that this is a sort of a simple way to think about treatment, and very limited tailoring was done, as I mentioned before, about the idea of trying to use a drug with a shorter half-life to help people fall asleep because you don't want to sedate them during the day if you don't need to. over time, it's become clear that there is more nuance to this story than people appreciated for a long time. Although I think it was appreciated by many people earlier, there are significant differences among these drugs. They're all different in terms of the pharmacology. The specific pattern of GABA-A receptors that they bind to differs for all of them. And many of them are similar, but there are some notable differences. So one of the challenges we have is that we have limited data on the different options that we use and what their effects might be in different groups of patients with insomnia. The drug Eszopiclone has been studied in people who have comorbid insomnia and depression, generalized anxiety disorder, post-traumatic stress disorder, rheumatoid arthritis, and chronic low back pain. And in every single one of those studies that was done, the drug improved sleep, but also improved the outcome of the comorbid condition. Every single one of those. Only 2 studies have been carried out in these populations with other drugs that are commonly used to treat insomnia, and in both cases it was Zolpidem extended release, that is Ambien, CR. And in these studies, people receive, let's say a depression study, people receive open-label antidepressant medication. Fluoxetine was done in the Eszopiclone studies. And then on top of it, they would get Eszopiclone or a placebo, or Zolpidem extended release and placebo, and outcomes were assessed in the 2 groups. And it was remarkably, the field was shocked, at least those who were paying attention to it, which is like 10 people, that the Zolpidem did not improve depression. It did not improve generalized anxiety disorder, but had the exact same effect on sleep. So something's going on here. These drugs are not all the same. So here is the Eszopiclone study. So we found that there was a robust enhancement of total sleep time and all other sleep measures. But at the same time, there was an enhancement of both depression response and remission, where this is the improvement in the Hamilton, where you exclude the sleep items, because of course these sleep drugs are biasing outcome because there's a couple of sleep items in the depression scales which shouldn't count towards depression therapeutic effects. And we analyzed in detail the outcome here to really see, are these sleep-like effects? But it was on core symptoms of depression like guilt and reward and things like that. So it really seemed to be a robust antidepressant effect. The same thing was found with the generalized anxiety disorder, that there was improvement in the HAM-A without removing the sleep items. So something interesting is going on there. The exact same studies were done with Zolpidem, with both the generalized anxiety disorder group and depression group, same improvement in sleep, no effects on outcome in terms of depression or anxiety disorder. So what's going on? So the story was present in animals but hadn't been translated to humans, that these drugs differ. And these studies are really the first evidence that there is a pharmacologic difference among these that is relevant to clinical treatment of insomnia. And as you can see in the picture here, the GABA-A receptor is made up of 4 peptides that span the membrane, and there's alpha, beta, and gamma. And the drugs we're talking about bind to the alpha subunit, but the alpha subunits come in different types. There's 5 different types, of which 4 are relevant to treating insomnia: 1, 2, 3, and 5. And at least in terms of this class of medications. And so there is specificity of clinical effects because these different types reside in different parts of the brain. So if you're a drug that binds to the type of receptor that sits in the cerebellum, then you're going to cause balance problems and coordination problems. If you bind heavily to the ones that are in the amygdala, then you're going to have effects on anxiety, things like that. That's the sort of model that emerged from the animal work. And it's clear there's differential binding in the animals. Here's a rat brain, which I'm not so good at figuring out the scans from rat brains, but if you bear with me, you can see that there are significant differences in the distribution of the receptors that include alpha-1, alpha-2, alpha-3, and alpha-5 subunits across the brain. You can see there's a lot of subcortical effects here in alpha-2 compared to the alpha-3, 5, and 1. And alpha, so they all have their differing distributions. And there's really good evidence that these drugs have differential binding. So the yellow end here is the therapeutic dosage for these medications. So this is Zolpidem, Ambien, Eszopiclone, which is Lunesta. And you can see at the border here, which is presumably the therapeutic level, Zolpidem is primarily alpha-1. The alpha-3 and alpha-2 are way lower. If you look at Eszopiclone, its biggest effect is alpha-3, and the alpha-1 is far lower. So what are the implications of this? In animals, there's evidence that the alpha-3 and alpha-2 seem to be more anxiety-reducing and possibly antidepressant. One of the reasons we can't tell that is we don't have any good animal models for depression, so really teasing that out is harder. We have better animal models for anxiety. But Zolpidem is alpha-1 specific. The most alpha-1 specific is Zalclon, which is Sonata, and that means it's going to hit hard sleep effects and cognitive effects and anticonvulsant effects, but not going to have these other properties which might underlie why Eszopiclone is good with pain and with depression and anxiety because of these myorelaxin and other effects. Alpha-5 is probably less important for these. So I realize I'm moving extremely fast through a lot of stuff, but to try and tie up this story, for these drugs, the benzodiazepines and non-benzodiazepines, some people have concerns about using them, but they are the most effective treatments we know of for helping people fall asleep. If you have a person who has trouble falling asleep, we really don't have any better options in terms of therapeutic impact. If you can get away with a lesser impact intervention for helping people fall asleep, that's great, and it's good to do that. But for people where there's a problem achieving that, this is the strategy I end up falling back to. There is some difference among these, and we don't have data on anything other than Zolpidem, the extended release form of Zolpidem, and Eszopiclone for insomnia occurring with these co-occurring conditions. But the fact that there is a therapeutic effect on the co-occurring conditions here with depression, generalized anxiety disorder, etc., is, to me, speaks for using them that preferentially in those conditions if there is a need to enhance outcomes or other cognitive behavioral therapy isn't available, doesn't make sense, or there's some factor that mitigates for urgency. Now I'm going to shift gears and talk about a new model for insomnia management that's emerged in recent years. And the prototype for this is antihistamines. Antihistamines are drugs that block the arousing effect of histamine, which actually comes from here. It's not a highlighted part of this slide because this was produced for other reasons. But this is the tuberomammary nucleus where the histaminergic neurons arise from, and they project broadly to a number of areas of the brain and mediate arousal. So blocking that arousal has the potential to enhance sleep. Now, you're probably saying, antihistamines? But that's a basis for a new model for insomnia. We've had antihistamines forever. We've got tons of experience with them. We know all about them. Actually, we don't. We've had lots of drugs that have antihistaminergic effects, but the drugs you think of as antihistamines are actually dirty drugs. I mean, they include effects on other receptor systems that cloud the picture in multiple ways. And that it actually wasn't until very recently that we had any data on what a highly selective H1 antihistaminergic drug does to sleep. Okay, with all this year experience with antipsychotics and antidepressants like amitriptyline and other drugs like that, drugs like diphenhydramine and hydroxyzine, and all these really are telling you about multiple receptor effects, anticholinergic effects, among others. It turns out that if you were to think about naming drugs by their pharmacology, then none of the things we call antihistamines would be close to the top of the list for what should be thought of as a prototypical antihistamine. The prototypical antihistamines available in the world right now are Doxepin and mirtazapine. These are two drugs that were approved for the treatment of depression, but that's a historical accident. I mean, they could just as easily have been approved for treating itch and allergy and those sorts of things. They are by far more potent and selective for the H1 histamine receptor than anything we call an antihistamine. And so there is an interesting possibility here. If you take those drugs, so Doxepin was approved for treatment of depression in dosages of 75 to 150 milligrams, and mirtazapine at 15 to 45 milligrams. If you take those drugs and you lower the dosage down, their antidepressant effects go away. But because histamine antagonism is by far their most potent effect, you can get a dose where they have only histamine antagonism. And that's where this story emerged, was we started to look at data on Doxepin in 1 to 6 milligrams. Right? Remember, the antidepressant dose is 75 to 150, and mirtazapine in the 2 to 4 milligram range. And it's only then we started to see what does H1 antagonism actually look like when you use it to treat insomnia. So just a little quick review here. This is diphenhydramine, and it's actually got some selectivity for H1 receptors compared to others. It's about 5-fold more selective over the next most important effect, which is M1 muscarinic cholinergic antagonism. Here's amitriptyline, and it's got a less of a margin over serotonin reuptake inhibition, the 5-HTT effect. And here's trazodone, which is not an antihistamine in that its largest effect is 5-HT2A antagonism in terms of pharmacology. But this is Doxepin. So Doxepin's effect, compared to its next most important effects, is a much greater spread, much greater difference. So we're talking about, a factor of like 100. So that difference means that if you go to, there should be a range of dosing where you can hit that histamine receptor antagonism effect and not have any other effects. And so that's what we saw, or when you go to 3 and 6 milligrams, it doesn't have any anticholinergic effects. It isn't associated with weight gain. It doesn't have any antidepressant effects. It doesn't seem to do much, but it does have an effect on sleep. And allergy. And allergists have actually known this for years. They often have used Doxepin in 10 milligram dosages for treating allergic problems in people. But one of the things, so this is a highly specific intervention. The only thing it's doing is blocking H1 histamine receptors. And what we found was surprising. When I looked at the first data on this, I said, wait, something doesn't make sense here. This drug hits its peak blood level in 3 to 4 hours. But we weren't seeing biggest effects then. We were seeing biggest effects in hours 7 and 8 of the night. So when people were at the end of their night. And another thing that was odd, the drug was helping people return to sleep, but not preventing them from waking up. We've never seen that before. Benzodiazepines prevent awakenings. They increase the arousal threshold. They make it difficult for you to wake up, which is why they work, right? They blunt your arousal. But these drugs were having as big an effect on the wake time in the middle of the night, but not preventing people from waking up, and this has no abuse potential. So here's just a slide on the over-the-night effects of this H1 selective antagonism. What you're seeing, higher means more minutes awake, and we've got placebo, the 1 milligram and 3 milligrams of Doxepin in older adults. So this is 3 milligrams, more than a 20th of the minimum dose used to treat depression. And you can see that over the night, the difference between placebo and drug is getting bigger and bigger, and the biggest effect sizes are here in hours in 7 and 8. Okay? Now, here's the peak blood level. Here, there wasn't even an effect in the 1 milligram dose. In the 3 milligram dose, there was some effect. The first, second, and third hour effects are clearly smaller. But one of the factors in this is that you're getting what looks like an arousal effect, which presumably is driven by histamine, which the drug is blocking. So this is a whole different approach, because everything we talked about before is enhancing sleep-promoting systems. This is blocking a wake-promoting system. So histamine is part of the awakening process that includes cortisol and other things that starts before you wake up, and in older adults in particular hits towards the end of the night, and this is one of their leading complaints. I guess I should say our leading complaints. That hits here, and this seems to be blocking that effect. Is a very different kind of approach. On the other hand, look at Eszopiclone. So big effect in the beginning of the night, big effect here, and as you get to the end of the night, there's no effect. But that's exactly what you want in this drug, because if you have a big effect in hour 8, you're going to have a big effect in hour 9. Blood level is decreasing exponentially. You're going to only have an incrementally smaller effect in hour 9 if you have a big effect in hour 8. And so the people who were selling this drug would be thrilled to say we have no effect in hours 7 and 8 because we know we're going to have minimal impairment later. If they did have a big effect, and there are lots of drugs that do, like flurazepam, Dalmane, people are massively sedated the next day. Look at Zolpidem. This is the extended release form of Zolpidem. Now, in this case, down means more wake time, so bigger down is worse, and you want to block that. So Zolpidem does a great job here at the beginning and middle of the night, but it drops off the map here in hours 7 and 8 for good reason, right? That it's safe to do that. So the problem with the benzodiazepines for treating sleep difficulty at the end of the night is there's no way to achieve that without sedating people during the day because blood levels are gradually dropping and therapeutic effects are proportional to blood level, and you can't have a big effect in hour 8 without having a pretty big effect in hour 9 when you're trying to walk around and do stuff and would be falling down. And believe me, people do have that kind of impairment. But the remarkable thing is that the Doxepin at 3 and 6 milligrams, even though it had this bigger effect at the end of the night, had no impairment when studied 1 hour later. This is a battery of cognitive tests: digit symbol substitution test, symbol copying test, visual analog scale. This is the triad of tests the FDA requires to assess for morning impairment for sleep drugs. And there was absolutely no effect. I was shocked when I saw this. I said, it's not possible. There's something wrong with the data. We can't have a biggest effect in hour 8 and have nothing in hour 9. It just doesn't make sense. And if you look at the reported adverse effects in terms of sedation during the day, Zolpidem, even though it didn't have an effect in hours 8 and 9, has an elevated rate, as does Eszopiclone, that's mildly elevated. And this is because we have individual differences. Some people are, in fact, getting sedated in hours 7 and 8, and then they're sedated in the morning. And this is before people had thought to lower the dose of Zolpidem because there's actually a well-known difference in metabolism in men and women that was being ignored. So this is driven more by women. But the Doxepin had this no increase in daytime sedation as an adverse event, even though it had that advantage at the end of the night. And in fact, in the older adult study, there was a lower rate of daytime sedation reported in the drug group than compared to the placebo group. And because of the selectivity of H1 antagonism, it's a very targeted effect. The overall side effect profile was quite benign. And you can see there's really a little bit of elevation in the younger adult study on somnolence and sedation, and really that was the only effect seen. In our older adult study, there actually wasn't any side effect that was greater in the drug group than placebo group. In fact, this is the only study I've ever been involved with where the drug group had lower side effect rates than the placebo group, and it was because headache got improved by the drug, which presumably is a histamine-mediated effect that people are well aware of. So this is a unique set of features that are driven by a selective blockade of H1 histamine receptors, and there's another side to the story that is linked to this, and that is linked to the idea that this drug doesn't prevent you from waking up, but it helps you sleep better through the night. Here is a study that was done in people just completed, where people had a 4-way crossover to getting Doxepin 6 milligrams, Zolpidem in standard dosage, and placebo. You had to have 2 different placebos because people were awakened at peak blood level for the drug, but the peak blood level happens at a different time for these 2 drugs. So we had to have 2 different placebo conditions, one for the Zolpidem and one for the Doxepin. And what happened was that we looked at how much sound it took to wake people up. And it turns out that with the Zolpidem compared to placebo, both placebos, it takes a louder sound to wake you up by a substantial amount. But the Doxepin, this is its control here, it was not significantly different from placebo in terms of the sound it took to wake you up, and nor was it in terms of the number of people that received the maximum dosage, or the group that was not, the proportion that was awakened by the technician was higher in the Doxepin group. That was the only parameter here that would suggest any elevation in the arousal threshold, but a really minimal effect compared to Zolpidem. And then the other is balance. So if you wake up and you need to function in the middle of the night, or you have to go to the bathroom, which is very common in people who have insomnia, there's a risk that you're going to have a fall with a drug like Zolpidem. But with Doxepin, there was absolutely no impairment in their ability to do tandem walks in terms of either how long they were able to walk before they fell or step off the head during basic simple tandem walk. So the idea here is that there's something unique going on with H1 antagonism. It was not what we gleaned from our experience with antihistaminergic drugs that we've seen in the past, because we never had a clean study of an H1 selective drug. Actually, we never had much in the way of studies with any kind of antihistaminergic drug. And there are unique properties. These drugs don't prevent awakenings, but they help people return to sleep faster. They don't blunt the arousal threshold. They don't impair you in terms of motor function or cognition. There's some data that supports that as well. There's minimal abuse potential. And it's possible to get an effect at the end of the night without sedating people in the morning, which is unheard of for an insomnia drug. So what's going on here? And my model for this, which is sort of the idea that there was a need for a new paradigm for thinking about insomnia drugs, is that when you block a wake-promoting system and you do it selectively, it's different than if you have an enhancement of inhibition broadly or even focally. But and the issue is that there are a number of wake-promoting systems. Histamine's only one, but there's hypocretin orexin, there's norepinephrine, there's serotonin, there's a whole bunch of systems that enhance our wakefulness, and you're only blocking one of those. And so if after the alarm, at the end of the night, it turns out that histamine is primarily the only wake-promoting system that's active. So you have an opportunity to block it and have an impact. If there are other wake-promoting systems that are active, then if you blocked histamine, it wouldn't have any effect because those other systems would keep you awake, right? So, at the end of the night, really histamine is the primary driver of the tendency to wake up, and so there's an opportunity there, because if you're blocking a wake-promoting system and it's not active, the drug can have no effect, right? But if there is activity, you can block it, and that's what happens with histamine. But after the alarm goes off, you wake up and noradrenergic activity kicks in, hypocretin orexin activity kicks in. It keeps you awake, even though histamine receptors have been blocked, and that part of the system is not critical for maintaining wakefulness and function. So the idea here is that there's going to be a divorce of blood level and therapeutic effects, and that there are factors that matter besides blood level, like time of day and what other systems are active and what are not active. And so the understanding what's going to happen with the drug becomes much more complicated. So who are the people who are best treated with antihistaminergic drugs that are selective H1 antagonists? People who have sleep maintenance problems, difficulty staying asleep, especially those who have early morning awakening. And then people who might need to wake up in the middle of the night and function. So I've used this really well with parents of infants who cannot afford to be impaired when they wake up, and they need to be able to wake up. And it worked remarkably well in the handful of people I've used it in, where there was a severe insomnia. Now, everybody gets disturbed who has an infant. The insomnia problem was that I've had parents who would get awakened by crying infant or whatever, and then wouldn't be able to return to sleep for hours. Okay, that's the problem. It's not being awakened. We all awaken. We all get tired in that setting. But people who then were suffering because they were basically awake essentially all night long and getting devastated by it, this kind of intervention can be quite helpful. And then people who have abuse liability, this is an obvious good choice. The next drug group I'm going to talk about, which is a related story, is orexin-receptor antagonists. Now, I realize some people are going to go at 9. The histamine story is really the one that is the prototype, and this is going to follow on that story very closely, because this is a selective wake-promoting antagonist. And selective is a very good term for this one. So this is the neurons in the brain that give rise to the orexin. And they are small in number, so 10 to 20,000 of them in the lateral hypothalamus. I once gave a talk like this, and I mentioned that, and someone came up to me and afterwards says, "You're wrong. There's 40,000 neurons." I mean, it's a tiny number, right? And and these neurons come here out of the lateral hypothalamus and project to other wake-promoting systems and keep people awake that way. And so there's a potential to enhance sleep by blocking that set of receptors in the same way that histamine blockade enhances sleep. And the effects of orexin antagonism are very similar. And one of the reasons for that is that orexin activation actually drives histamine release. So there is some overlap, but it also has independent effects on a number of other systems. So this set of drugs has a more robust effect on maintenance than onset, but these drugs have a bigger effect on onset than histamine antagonists. And the one that is approved for this, suvorexant, has an indication for both sleep onset and maintenance, whereas the H1 selective Doxepin does not. It only has an indication for sleep maintenance. But they have effects in the last third of the night without impairing morning function in the same way as antihistamines do, because I believe what's happening is the orexin is triggering histamine release, and you can block that at the end of the night, and you can block that at the level of histamine receptors or at the level of orexin receptors before the histamine is activated, so you get a very similar kind of effect. Now this drug, another difference is that this is a scheduled class of drugs, and the interesting thing is it's not the same as Zolpidem. People have similar liking of orexin antagonist to Zolpidem at the therapeutic level, but as you increase Zolpidem, you get an increase in liking, and you don't with these drugs. So it's capped. But nonetheless, they are scheduled drugs. One of the reasons we had some intuition about this class of drugs is because and that it might be useful for insomnia, is that the loss of these orexin neurons appears to be the pathology that underlines narcolepsy, where people have sleep attacks during the day and a bunch of other symptoms. And there was a fear that these drugs would lead to those other symptoms, which are paralysis setting in when you get emotional, and hallucinations as you're falling asleep and waking up, and paralysis as you're falling asleep and waking up. Fortunately, the drugs don't seem to do that in any substantial way. But there's also a relationship to arousal, and this system mediates stress, anxiety, hunger, and reward-driven arousal. So there's some interesting possibilities for treating subtypes of people with insomnia. So this just goes to show you the effects over the night. Notice the effects are as large or bigger at the end of the night than at any other time, and they're smaller at the beginning, but still finite. This is a study mirroring the one that was done with the Doxepin in terms of arousal threshold and cognitive function at peak blood level. This one was done in monkeys. There is a study that was done in humans. It's not published yet, but it shows that the monkeys had less cognitive impairment with the DORA, which is the dual orexin receptor antagonist, than Eszopiclone or diazepam. And also an interesting thing here was that the monkeys were given a conditioned stimulus, and they were not impaired in their waking up to the conditioned stimulus, but neutral stimuli they didn't wake up to, which is really interesting. So there's a reward-driven, component to this that interestingly, in this case, it allows, there's some salient thing that you need to wake up for, it allows you to wake up for that, but prevents awakenings that might occur due to things that are not important. So this kind of class of drugs, like Doxepin, is useful for people who have trouble sleeping at the end of the night, have early morning awakening. But and also could be useful for people who need to wake up in the middle of the night and function, although I don't have as much experience with that, so I haven't verified that in my clinical population. But unlike the Doxepin, this also helps with sleep onset. So if you have an early morning awakening person and trouble falling asleep, this is a good drug for those people. The other question is theoretical at this point. There's about, I think, 15 studies going on right now looking at effects of this orexin receptor antagonist, suvorexant, in particular subgroups of people with insomnia, and target groups of interest based on the effect, the physiology of orexin are people who can't seem to shut down or trying to sleep in an adverse circadian time, like shift workers. And the reason for this is that narcolepsy occurs in people with orexin deficiency because as sleep drive builds up, the longer that they're awake, everybody tends to get sleepier, but they can't tolerate any sleep drive building up during the day because as they start to, while we have orexin that we release that prevents us from falling asleep as sleep drive builds up, they don't have it and they go right to sleep. And then they're fully rested after a 15-minute nap, and then they start the cycle again, and they start to build up sleep drive, and as soon as it builds up, they fall asleep. Because orexin's main job in life, in its life, I guess, is to help us have a sustained period of wakefulness. I'm anthropomorphizing here, but its release increases over the course of the day in the face of our mounting sleep drive, and if it weren't for that, we would be like narcoleptics. We'd fall asleep, periodically throughout the day. So people who do shift works, who are trying to sleep at a time of day when they normally don't sleep, could potentially benefit from this because what prevents us from sleeping in the middle of the day is orexin, primarily. Unless you have stress or other things, and then you have other systems that are kicking in, of course, like norepinephrine. But there is a component to stress-related arousal, anxiety-related arousal. So there are studies going on with shift work, with people with anxiety disorders, with substance-driven insomnia and other things. I'm now going to just hit a few points related to other classes of medications that are more to round out the story and then stop. So there are selective drugs that help us sort of tease apart the array of possible systems that one could affect when they're treating insomnia, and one of those is norepinephrine. We know it plays an important role in arousal. There's some evidence that people with insomnia have elevated serum norepinephrine levels. It's not clear that that has anything to do with their central activity, but the finding is out there. And we do have an alpha-1 adrenergic selective antagonist that has been used in a very limited context, and this is prazosin, and Tom is immersed in this in a deeper way than I am. But it's been used to treat people who have nightmares and sleep disturbance in post-traumatic stress disorder. And we're in a funny place with this because there's like 4 positive studies that have been done, and then one big trial that was done that was meant to be the definitive study to establish this drug as therapeutic, and it didn't seem to work. So I think we don't know really where we stand with this, but it's an interesting mechanism. But we haven't used this in any kind of insomnia other than this kind of setting, and it's really hard to know how to map it. But there is an interesting animal model that is relevant here. So if you put an animal in a new cage, a rat, or you put a male rat in a cage with another male rat, or you put a male rat in a cage that had another male rat in it, in all those situations, they don't sleep. And so it's a model of insomnia, and the physiology suggests that there's an important noradrenergic role in that. If you lesion the locus ceruleus, or you give interventions that block norepinephrine receptors, and interestingly histamine receptors, but primarily norepinephrine receptors, you can prevent this response. So there is some role here, but at this point, I use this in people who have nightmares because there's absolutely nothing else that works, and in my hands clinically it's worked actually quite well. But there are no other options that work in any robust way in nightmares, particularly related to post-traumatic stress disorder, and the effect of this drug is quite profound in some people. So, and it's so targeted that the side effect profile is quite minimal. It's an antihypertensive. It's generic, been on the market for many years, so it's got one side effect, orthostatic hypotension, and that's it. And it has some sedation potential, but if you work with an internist, if people are antihypertensives, you can use this easily and warn people to get out of bed slowly the first morning after they use it, but you have to gradually taper up the dose. There are selective melatonin agonist drugs, and the reality is we really don't understand much about this system. It is a very complex system, and as you are all aware, our hormone systems are very complicated, and this is a hormone. This is a hormone that's released from the pineal gland in the evening, binds to the melatonin receptors, and melatonin has very complex effects that the field has been trying to tease out. One thing is clear, it's not a sleep drug. It's not in terms of insomnia. It doesn't help people fall asleep faster in any meaningful way. But it is the best tool we have for shifting people's time of day at which they sleep. If you give it at a certain time of day, it has a dose-response curve so that depending on the time of day you give it, you move people forward or back. And it's actually complicated to use, but it does that better than anything else for people who are phase delayed or advanced, that is, tend to stay up late and sleep late, or go to bed early and get up early. But there is a melatonin agonist, which is like 100 times more potent at these receptors than melatonin, and it is reliably helps people fall asleep, but its effects are quite minimal. People don't report very much benefit, although if you do a sleep study, you can consistently show a benefit. But just to speak to the sleep-related effects of melatonin being clinically important, people may be aware that some beta blockers, atenolol and metoprolol, impede the release of melatonin, synthesis and release, and they're actually associated with insomnia. And if you give people melatonin, it fixes that problem. So that is a specific indication for use of that drug to treat a sleep disorder, if you will, in some small percentage of people. But really, this is a great, so the Remeltion is a great drug for helping people fall asleep if they're finding benefit with it, which is a modest number of people, but when it works, its side effect profile is extremely benign and has no abuse potential. So for people who get benefit, this is a great risk-benefit trade-off. I'm quickly going to finish by just talking about antidepressants and antipsychotics. The story is the same on both. These are very dirty drugs that we've used, and by antidepressants I mean sedating antidepressants, tricyclic antidepressants. And these are used in their antidepressant dosages primarily. The most notable of this is trazodone. Mirtazapine we talked about, and Doxepin we talked about, but here we're talking about the usage in the higher dosage range. And we don't have data on efficacy and safety for treating insomnia for any of these except trazodone, and the trazodone study was actually negative. So there was a study comparing trazodone and Zolpidem at 50 milligrams, and there wasn't a therapeutic effect in the second week of a 2-week study on any parameter of sleep with the trazodone. That's not to say that it's not a good drug. The problem with trazodone is there are important polymorphisms in its metabolism that affect a significant number of our members of the community. So there are some polymorphisms that lead to a buildup of the drug, or it's a sedating metabolite. There's also a polymorphism that leads to the buildup of M-chlorophenylpiperazine, which is a stimulant-like effect, an anxiety-inducing effect. So you have to tailor the dosage of this drug very carefully to people. You can't just pick 50 milligrams and give to everybody. So we really have never had a fair trial of trazodone to figure out whether it's helpful or not. Certainly, if you believe the community in terms of voting with its feet, it's like the best insomnia drug we have, because it's used more commonly than others. But this is part of this cultural phenomenon that's been with me through my whole time in the field. That is, people use this drug without an evidence base, and somehow it became part of the culture, and obviously it's helping people, and if it's helping people, fantastic. I have patients whom it's helped. I'm not going to take them off it because there isn't a published study saying that it's not therapeutic. Right. So these drugs are, because they're dirty and they hit lots of receptors, are good for people who are hard to treat, right? You want to hit a lot of receptors there. You want to block arousal in any of the ways you can. And the same is true of the antipsychotics. The one that's most often used here is quetiapine. And, you know, people used to use them in a more cavalier way than now for treating insomnia. I don't know what the data on this are about how commonly it's used, but there are a number of cases of people developing insulin resistance, tardive dyskinesia, and other stuff. This is not a benign group of drugs, and you use it if you have some urgent problem you need to address in terms of insomnia, but boy, I would stay away from this. There's no data on the efficacy or safety of any of these for treating insomnia. So very complicated comorbid cases. Obviously, if there's a psychosis or bipolar disorder or something like that, I can imagine using it. So this slide sort of summarizes the matching strategy that I think we can do at this point in history. I actually timed this Grand Rounds presentation with the idea that I was going to present new data on the STAR-D of insomnia that I've been part of, that's just completed, but the data aren't out yet. I was expecting them to be out by now, so I don't have that to present, but stay tuned because that should help us think about how to best treat people in clinical practice. I'll stop there and see if you have questions. So that is a strategy I have used some. There's no data on it. There's a logic. There's no pharmacologic interactions between them that I know of, and it has been helpful for people. I think the one thing that I didn't mention in terms of combinations is combining. I could have done a whole separate talk on this subject. There's data on combining cognitive behavioral therapy for insomnia with medications. I presented it as if it's one option that's an either or, but it's not. Most of the time, we do cognitive behavioral therapy first or along with insomnia medications. And what you get by doing that is helping people immediately with a medication, and then you get the long-term benefit of the cognitive behavioral therapy if you do it right. The wrong way to do it is to give people cognitive behavioral, to give people a medication, stop it, do cognitive behavioral therapy and medication together, and then at some point, just after the cognitive behavioral therapy is done, stop the medication. The reason that doesn't work is because people don't do the cognitive behavioral therapy if you eliminate their sleep problem with the medication, or you cut it down substantially. What we found is if you taper the drug in the middle of the course of cognitive behavioral therapy, then you get the best of both worlds. Then they do the therapy and they get benefit from it. So combinations are great, but we have no data on any. But we do have data on the combination of CBT-I with medications. Please. Thank you. What kind of patients? Oh, yeah. Okay. Oh, no, Zolpidem does affect cognition. So it absolutely does. So if I suggest that, I apologize. It has the full kinds of range of impairment associated with it the others do. It looks like you can't get the sleep-enhancing effect without blunting cognition and impairing balance to a degree, because those are linked in the pharmacology. What the Eszopiclone had was these other comorbid therapeutic effects. So obviously, you're raising the question, these are people who are vulnerable to cognitive problems, falls, so on. We don't have tremendous data on how to do this in a sort of step way. I think the first thing I would always do is cognitive behavioral therapy if you can. If a person has a sleep maintenance problem, and the majority of people who are older adults have troubles with sleep maintenance, and particularly at the end of the night, and then a drug like Doxepin or an Orexin antagonist would be a good choice. If the problem comes in if you have severe sleep onset problems, and then you do your best to avoid using a benzodiazepine-related drug. If there's some very compelling reason to do it, I would do it for as shortest period possible. And so one of the things we didn't talk about is how long do you treat somebody, which is a whole other discussion. We have data on nightly use of about 5 drugs now up to a year that shows that none of them have lost their benefit over time. There's not been any evidence of pharmacologic tolerance or withdrawal. But there is cumulative risk. And in a trial, you can't really pick that up because the falls and the accidents and the nighttime wanderings and stuff are rare enough where it just doesn't come up in a clinical trial. So I always try and treat people the shortest period of time possible. How short is short, or how do I do that? The way I do it is I start people on a medication and I say, look, we don't know how long your insomnia is going to last, and while you're on the drug, we may not know if you still have it. So I make a contract with them and say, let's say in about 3 months, we're going to do a taper of this medication, and we're going to see if you still need it. And then we look at them in terms of risk-benefit, and once they're off the medication, we say, are you better with or without it? And taking into account the risks that are inherent in some of these medications, and make a decision on a case-by-case basis, time point by time point. So I never consign somebody to a long-term, whatever that would be. They might end up on years of treatment, but it's through a series of decisions that happen at a set of selected time points where we've tried to stop the medication as soon as we can. Yeah.
It's hard to get approval for Selinor.
Yeah, so this is a great point. So some of these drugs are branded. They're gradually going to be going off their patent protection. And I have the same problem. Doxepin is handy because while it's a branded drug still, there is a generic available. And the best one, which is dirt cheap, is a liquid, which happens to be just around for reasons that I have no idea, in a dosage of 10 milligrams per milliliter. And so the problem is you're going to give people 3 to 6 tenths of a milliliter, which is hard to do unless you ask the pharmacist for a pediatric syringe or eyedropper that has fine enough gradations, and you can do that. You put it in a glass of water, and they drink it. And I've had lots of people have no trouble with that. Occasionally you'll find somebody who doesn't like doing that, but the other option is the 10 milligram generic, which you open up, and then you have powder, and then you have to take some of that and put that in water and drink it. The problem with 10 milligrams is that we don't have any data on its selectivity. And it's clear to me some people get evidence that it's losing selectivity, and then you're not getting the true benefit of the drug. You're getting anticholinergic effects and weight gain and all that kind of stuff. And so for me, for people, particularly where risk-benefit is critical, older adults where they might be vulnerable, you have to get the dose down as low as you can. And the way I do it with the liquid is I start out with 3 milligrams, and I titrate down if there are side effects and up if there's benefit. With a liquid, you can go fine gradations with the hope that you get a therapeutic effect without any side effects, which is in theory possible.
Do you get a lot of patients using marijuana for sleep, and what do you tell them?
Well, I haven't been practicing in California that long, so it hasn't happened to me yet. But I occasionally would come across this. There is very little data on marijuana's effect on sleep. You would think there'd be a lot more. I looked into this about a year or two ago. I don't really have a good sense of what to tell people, but I go with this like I go with people who come in and say to me, I've tried X and it's working for me great, and my doctor thinks I should come off it, but I'm not having any side effects and I'm doing well. If it's helping, great. But if they're coming to me for help, it's usually because what they're doing isn't working, right? So then I would sit with them and say, okay, we need to think about whether you should be continuing this or not. And by the way, would you mind stopping, hanging around for a minute after we're done here? Okay, thanks. Yeah.
That's a really nice talk.
Thank you.
Do you have any comment about whether you think that 5-HT2 receptors involved with sleep in some
Yeah.
fashion? Because people have posited that, and there's some data that is, as I recall, kind of mixed for methazidone,
Yeah.
which is primarily a 5-HT2.
So
Any thoughts?
I like methazidone. I use it periodically. So there's two pieces of data to bring to the table. There's animal data showing that 5-HT2 antagonists enhance sleep, and what they do particularly is enhance slow-wave sleep. And 5-HT2 agonists decrease slow-wave sleep. I was part of like 3 efforts that happened, I think, in the 90s, maybe early 2000s, to study drugs that were selective 5-HT2A antagonists. So there's problems here because there's A and C, and actually there's a multiple set of subtypes. But the A antagonists have been studied, and they have a very interesting effect. They seem to decrease number of awakenings without helping you fall back to sleep. And so the problem with that was that it's not helpful enough for people for it to be able to get on the market, any of them. Some of them, one of them was really close. Sanofi had one, but then there was a problem with diverticulitis that ended up leading to it not making it to the market. So it's partly an accident that none of them made it to market, but primarily what they do is prevent awakenings, interestingly. The reasons I don't think anybody understands. And in a selective way with minimal side effects. Actually, one study we did with it, that actually failed with one of these 5-HT2A antagonists. There was no therapeutic effect and no side effects. And so there was a concern that the drug had not actually been given to people. I mean, I was thinking there had to have been some, if there had only been a side effect, then I could be confident this didn't work. I just don't know, And unfortunately, we hadn't taken blood levels for people, but, that there might have been some problem in the manufacturing process that led that did not work. But they're very benign in the dosages used to treat sleep, but none have made it to market. So I just don't know the answer, but there seems to be, some benefit. Nifazodone hasn't been studied, as you know, so very well anyway. Yeah. Yeah, well, so the standard dogma there is that is to use melatonin to help with the shift. That's complicated because when you're traveling and you're in a plane for like 10 hours, you end up with complications because of when you sleep and when you don't sleep. And so part of it, part of it is about the strategy of how you plan your sleep. And typically people say you should stay awake until bedtime in the area that you're arriving in, which I know is horribly difficult. I actually find that that to me the big challenge is that I usually am traveling somewhere and I have to perform like the morning when I get there and I've got to sleep on the plane, and then I use a medication to sleep on the plane like Zolpidem is what I tend to use. But that's a different idea than trying to get adapted to the new time zone as fast as possible. If you're going to try and do that, then you want to take melatonin and you want to use it about 4 hours before bedtime in the new time zone. You can even start that before you get there, and you dose it at about half to 1 milligram. One thing people get confused about, I'm confused about, is that if you go to a store to buy melatonin, it is 10, 20, 30 milligrams, and that actually doesn't make any sense because melatonin is released in a pulsatile way. It's a hormone, and it shifts you, as I mentioned before, in a different direction depending on the time of day that you take it. If you take a really big dose, then it moves you forward from part of its time in your body and back for the rest of the time, and you get no effect. So you have to hit it in a targeted way by using a low enough dose. So that's the strategy that's usually recommended. Tony? I am. Yeah, there's Eszopiclone, yeah. No. So I actually tried to encourage that, and it wasn't in the cards for the company, and it's very hard to get that kind of thing funded by NIH because they see it as having commercial potential, so that has never been done. But my hypothesis, and actually when the study was originally started, I lobbied hard for having an Eszopiclone group without an antidepressant medication, just to see, and everybody said, well, why in the world would you do that? I mean, this isn't an antidepressant, it's an insomnia drug. I said, yeah, but we won't know if by chance we get a therapeutic effect in depression. We won't know if it's because it's an antidepressant or if it's because of sleep effects. And lo and behold, we got that benefit, and then I got to say I told you so, but it didn't do anybody any good. Yeah. Yeah, I pretty much do. I think, but the way I do that is not to say benzos are bad and non-benzos are bad too, that they're all different. So like clonazepam is a drug that's an alpha-2, alpha-3 more specific drug than, let's say, diazepam or, and so that one is good for mild relaxation and seizures and anxiety, and a lot of them hit all of them, but some of them are more selective, and clonazepam is. They all need to be thought of on their own. They're not the same. The more of the benzodiazepines are broader, but we just sort of glossed over that whole story historically. So just to give you an example of this, there's no dosage of Zolpidem where it has anxiolytic effects. This is because it's strong at this alpha-1 type. So if you put rats on a maze, a radial maze that's got a bunch of arms. Rats like to stay in a closed part of the maze. There's parts of it closed, parts of it open. But you put food out there in the maze, and the measure of anxiety reduction is how much time they spend in the uncovered areas of the maze. This is called the elevated plus maze test. Well, with Zolpidem, there's no dose at which they spend time exploring the open part of the maze, because before they get there, they fall asleep, right? So, it's very good at helping you sleep, but there isn't an anxiolytic effect. Whereas with Eszopiclone and with clonazepam, there is a dosage where they'll go out and run around and have an anxiolytic effect evident. So there's differences among these, and the pharmacology in animals is much better developed than it is in humans. Yeah.
Just one more, right?
Yeah.
Curious about the intersection between antidepressant effects, serotonin 2A, and dream states. So, in our lab, we give a 2A agonist that seems to put people in a dream-like state. We think it's good for depression. Some SSRIs, people have strange dreams. Is this an epi phenomenon? Is this related mechanistically?
No, there is an interesting and complicated story there. So LSD is a serotonergic drug, right? And we know that it's thought to act via 5-HT2 receptors in some ways, and so there is an effect there, but it is probably receptor subtype specific. And I don't know what the hypothesis is about what leads to that. 5-HT2 antagonists have not been notable, the selective ones, for causing nightmares. 5-HT2A antagonists don't. And that's what we studied most in sleep. Beyond that, I don't know in terms of data. But you're right, antidepressants that are releasing of serotonin and broadly hit serotonin receptors can increase nightmares, and I don't know if that has anything to do with the hallucinatory potential of that receptor system. It's a great question. Thank you.